As many as 20 million people could lose their health insurance coverage if recently proposed Medicaid cuts are enacted. In the face of these and other drastic changes to our nation's healthcare system, I've asked Kat Latet, a healthcare and social policy consultant with a wealth of knowledge about Medicaid, to join me today for a discussion about Medicaid, what it does, what it doesn't do, how it works, how it doesn't work, and more importantly, we'll answer the question, who benefits from Medicaid? Thanks for joining me today, Kat. Let's start by answering some of these important questions. I've been doing this work for a long time now, a little over 20 years, and I'm always surprised, I guess is the right word, the number of people who don't actually know what Medicaid is, even when they themselves are a participant in Medicaid in some way. So I think it helps us to go all the way back to the beginning, to 1965, when the Medicaid program was initially created. And it was created at the same time as the Medicare program. And its objective then, like with the Medicare program, was to provide health insurance to individuals with low incomes. So when Congress created the Medicaid program, it recognized the critical role that health insurance coverage plays in ensuring the economic well-being of people as well as their health. And so I think understanding that is really important as we start to look at the cuts that are being proposed by the 119th Congress and what has been put forward as priorities under the Trump administration.
Yeah, I think that's a really great point, Michelle. And I think it's also important to highlight as we're really digging into sort of the evolution of the Medicaid program and thinking again all the way back to when it came about. It's just recognizing that when Medicaid came forward, the federal government really trying to overcome the opposition of southern states resistant to civil rights gains, which could be seen if Medicaid was going to be passed. The federal government did give states a tremendous flexibility that allowed them to, in certain cases, underfund Medicaid or limit Medicaid eligibility in a manner that oftentimes disproportionately impacted racial and ethnic minorities. And the reason why we bring that up is I think it's important as we move into both, looking at, again, the evolution of Medicaid over time and where we are today, this idea of sort of state policy being able to really impact the shape of the Medicaid program, both at the local, state, but then also the federal level as well.
And I think that raises an important point about the Medicaid program. Unlike the Medicare program, the Medicaid program really is meant to be this state-federal partnership where the federal government sets minimum requirements that states have to meet, and then states have the opportunity to introduce new and different ways of doing things as long as it fits within requirements or that they've been given certain permission to change some of the requirements through waivers and things like that. I do think, though, that is why we see such differences across the nation. There's the funny, not funny saying among Medicaid policy experts that if you've seen one Medicaid program, you've seen one Medicaid program. And I think it's why we're also seeing, when Medicaid was initially enacted, Arizona didn't implement Medicaid, I think, until the early 80s. And we're seeing that now through the Medicaid expansion, where we still have 10 states that haven't implemented the program, the Medicaid expansion, even though it's been available for 11 years now.
Yeah.
And so as, we think about those evolutions over time, I think it's helpful to start in sort of what the traditional Medicaid program, how it was started, like who was initially covered and what they were thinking. And so it is important to understand that under the traditional Medicaid program, not all individuals who are low income qualified for Medicaid. In general, only children, people with disabilities, pregnant women, and some parents were eligible for the program. And you actually see that still today in certain states that continue to have very restrictive Medicaid eligibility. But the inclusion of these populations was intentional at the time. Like you talked about the opposition from southern states. The architects of the Medicaid program started with these populations because they were considered non-controversial populations. They were typically not in the workforce. They typically didn't have access to other forms of insurance. And so they started there, but the architects never intended for the program to stay there. It was always meant to be a starting place, and the hope and expectation is that over time, through iteration, the program would expand and cover more people who needed access to insurance, who otherwise didn't have access to insurance.
Yeah. And I think something that's, as we think about this term, non-controversial, I sort of use, air quotes, if you will, because I think we'll touch on this as we move forward in this sort of discussion of this idea of sort of who is deserving of care and coverage and what that looks like. And I think that still is present today as we're looking at proposed cuts.
Yeah, and we're absolutely seeing that. The most significant change in the Medicaid program happened in 2010 under the Affordable Care Act, when Medicaid was finally expanded to childless adults with low incomes. And it's been the split in terms of, is that population needy or deserving? That conversation comes up over and over again. And you particularly see it in, again, the 10 remaining states that haven't expanded. But I think, again, and we'll get into this as you alluded to, it goes back to that question of, what was the point of Medicaid? Was it meant to be health insurance, or was it meant to be a welfare program? But just to circle back to the Affordable Care Act, it is by far the most significant expansion we've seen, or most significant evolution we've seen in Medicaid since 1965. And the Affordable Care Act not only expanded eligibility, it also created a lot of pathways for innovation that I think we're going to talk about a little bit later.
Yeah. It was an incredible time. I still just remember it so well. When that was happening, I still have the sort of certificate that they, granted that you were part of the, work and sort of trying to move that effort forward. So I think it's just, so important to pause and really recognize the impact that Medicaid expansion has had on so many people in so many ways across their life. One, it is a coverage program, and it's allowing people to address being uninsured and sort of what that can limit for folks. And, we did see within Medicaid expansion, the uninsurance rate drop overall across the country, and specifically for Latino and Black individuals across the country, uninsurance rates really decreasing, specifically in Louisiana, which is an interesting state to consider because of where it is in the country. And thinking through sort of their decisions related to expansion, you actually saw data looking at sort of related to access problems, sort of having fewer cost related access problems, reporting disproportionately larger improvements in having a usual care provider. Even though, we know inequity still exists, we know that having an insurance card does not equal, having access to a provider, but it really can break down so many barriers to that, and also really just support financial stability in a family unit and for individuals who, are trying to move their lives forward towards wellness.
Absolutely. And that really highlights the importance of the Medicaid program today, which genuinely cannot be overstated. The Medicaid program is now the largest insurer in the country, covering about 80 million people, which is about 1 in 5 people living in the US are covered under the Medicaid program. It accounts for 20% of our healthcare expenditures nationally, which is about 1 out of every $5. And when you look at specific types of healthcare, for example, long-term care, Medicaid is the largest payer of those services. So Medicaid pays for more than 50% of long-term care costs in the country. So we're talking nursing home and home care services for people who continue to live in their home. It is the largest payer for behavioral health care. So individuals who need mental health treatment, who need substance use disorder treatment, Medicaid is the largest payer for those services. And not a lot of people realize that about half of births in the country are actually paid for by the Medicaid program. And so it has significant impact for people who have the coverage, for our healthcare system, which accounts for a huge component of our economy nationally. But when you think about it, locally and in some places across the country, I'd say in many places across the country, the hospital in that town is the largest employer in the town.
Yep.
So it has huge economic implications. It also is necessary to help the insurance market and the private insurance market and Medicare work more efficiently and affordably. And so when people who are privately insured don't understand or don't pay attention or don't think it's important to them to know about changes in the Medicaid program, that is fundamentally wrong, because what happens in the Medicaid program affects how our healthcare system works overall, which directly affects how our private insurance works. And so you can think about it this way. If people who have disabilities didn't have access to Medicaid, they would need to get that coverage through the private insurance market. And the private insurance market isn't currently set up in the best way to provide coverage to those populations. And so that then affects the cost of private insurance when people have to come into that and not be in the Medicaid program. It's also an economic driver for states and communities. It's not only about supporting populations to make them healthier. As we talked about, the major employer in many localities is some form of a healthcare entity, whether it's a hospital or an insurer or a major clinic or whatever. And so it really does impact our economy. And, the Commonwealth Fund studied the impact of Medicaid expansion in particular in states and found that over 1 million jobs would be created if states that hadn't yet expanded would expand Medicaid, because Medicaid is a job creator. And we'll talk about work requirements and things like that later.
Definitely. I think the other piece that's really interesting, I think you touched on all of the places in which, again, it impacts, but even, going back to long-term care. And I think especially as we are seeing so many of our parents and, people really having to engage in understanding, care work and what that takes and how much it costs and who's covering that. And I think, again, just that intersection that Medicaid has across all of our lives. We've known people or ourselves have given birth, again, just sort of that intersection of that within our communities. And I think it's so important to recognize and understand that Medicaid touches us all in so many different ways. And I think just really highlighting that, I think you touched a little bit on that Commonwealth study. And again, not to make this podcast about Louisiana, but I find it a fascinating state to really think about the impacts, because it is a state where you are looking at it's definitely is a more red state. You're looking at just sort of challenges as we move forward. And so thinking about some of the impact that Medicaid expansion has had on that state, researchers have seen that there's been a documented higher GDP, increased state revenue, jobs, higher growth in healthcare wages compared to other industries, and really looking at just again, that sort of cascading effect that it has had on the state in comparison to states that have not decided to move forward with expansion. They've seen lower rates of hospital closures, decreases in uncompensated care. I mean, just again, sort of the list goes on of, I think, the power that Medicaid has had both on impacting, most importantly, I think, individuals' health and well-being, but really in the community's health and well-being.
Absolutely. And the findings for Louisiana, are not unique to Louisiana. And I think that is a critical point. Every state that has expanded Medicaid to date has seen similar positive outcomes. The magnitude varies and the impact in one area over another might be different, but it is positive impact across the board. And that goes to that vital role that Medicaid plays in our societies and our social safety net, from keeping people from incurring large medical debt, which further increases rates of poverty, to also, I don't know that there's honestly anyone left in the country who hasn't been affected in one way or the other by the opioid crisis.
Yes.
And the Medicaid program, covers about 40% of adults receiving treatment for opioid misuse disorder. It is incredibly important from that regard as well. And then what's necessary to understand is at the state level, the Medicaid program tends to be in the top 3 budget line items in any state budget, but the majority of those funds actually come from that federal state partnership and their federal dollars. And so states are able to provide these resources and these services at a reduced price because of that federal match. And absent the Medicaid program, in order to provide these care services, the states have to figure out how to pay for it out of state-only funds, or the services have to go away. Mm-hmm. So reductions at the federal level have significant impact on state budgets. It's not a small amount of state budgets. It's really right up at the top. And so the impact at the state level from a revenue perspective, from a tax perspective, and from the state's ability to meet its residents' needs is significantly affected by changes at the federal level with the Medicaid program.
Yeah, 100%. It can't be overstated what the impacts can and will be if what we're seeing being proposed at the federal level, moves forward in, any sort of shape or form. I think it's just that recognition of these impacts and the cuts that are being proposed are not going to, it's just going to impact everybody. We can't sort of move around that. And I think, there's a variety of, as we sort of maybe transition into this space of sort of talking about what might happen, what's coming forward, what's being proposed, what does this look like? I think there's a variety of sources that we had been able to pull from prior to legislation being put forward more recently. And I think a lot of that information was pretty scary. Looking at Project 2025 and looking at past policy proposals from Republicans, looking at what was trying to be passed in 2017 but was not successful. And so, we now have the budget reconciliation markup from the House sort of after the first draft that was released, which was looking at $2.3 trillion in cuts to the Medicaid program over the course of 10 years. The markup is looking at about $880 billion over the course of 10 years. And that is still, again, an impact that is going to hit every community, every population that is covered by the Medicaid program. And then again, in this indirect way with respect to the way in which Medicaid impacts our economy and really populations overall. I think what's interesting, and I will, say that I haven't fully dug into what the Senate has proposed. It was more recently released, but I think it's been interesting sort of watching the discourse across the different houses within our Congress, as well as the executive branch. With respect to the Senate is looking at sort of a two bill approach related to the budget reconciliation. And I think I read a quote somewhere from Senator Chuck Grassley saying, maybe we don't want to face the politics of the Medicaid program in this first bill. Really, let's look at that potentially in the second bill. And so I think, it's an interesting sort of tug of war right now. I know, we had the president come out and say, I think it was yesterday, maybe it was the day before, saying one big beautiful bill for the House, but then also saying that they were going to, really protect the precious programs of, I think that was the quote, Medicaid. So it's just, I think it's really clear right now. I think there is a lot of noise. There's so much going on. And so I think it's helpful for us to start to kind of dig into, okay, so what's at stake? What might be coming forward?
And I think it is important to understand, just take a quick step back. But why is any of this even happening right now? And I think there's a twofold answer to that. First, and sort of most practically and immediately, is the tax cuts that were enacted under the first Trump administration are coming up for renewal. And in order to adequately fund those, they have to find other places to reduce spending in the budget. And initially, they were looking at trying to fund the tax cuts, which is something like $5.5 trillion, without leaving a deficit. I think since the beginning of January, we've seen some walk back from that, which is why we went from $2.3 trillion in spending cuts for Medicaid to about $900 billion in spending cuts. But that is a fundamental driver of why this is happening now. Like any household knows, you can't spend money without taking in money, without having a deficit. And so if we're taking in $5.5 trillion less, then we've got to spend less money. It's just kind of basic math. But while that is true, I think there's also been this long philosophical divide about what the Medicaid program really is or should be. And I think that gets us back to the question of, is it a health insurance program or is it a welfare program? And I think many proponents of, drastic reductions in Medicaid lean more towards this idea of it being a welfare program. And so only the truly needy or the truly deserving should have access to it. And so we need to reduce the overall size of the program so that we can make it work for those who need it, who are truly deserving of having it. And for me, that is fundamentally wrong in terms of what the Medicaid program is, even if you just look at the text of the statute, which says it is assistance for the provision of health care. It's really very clear in the statute that it's a health insurance program. But I think we've had this ongoing debate in division since 1965 about what it is and what it's meant to be. And then I think it gets you into, okay, so then who's truly needy? Who's truly deserving? And how do you even talk about that?
Yeah. And I think, I have really strong beliefs about, that related to we all are. And, we all will and can find ourselves in spaces that, we will need support. And I think, again, coming back to just really fully understanding where the program sits, who is it covering, what services is it covering. I think there are probably a lot of people that are considering how, about the cuts, thinking about, I think there's been a conversation around fraud, waste, and abuse, and how is this going to address, let's address that. And I think, that is really really blocking kind of in plain sight that you're not, with the proposals that are on the table right now, you're not getting at fraud, waste, and abuse. I mean, you are really dismantling the program. And where I was going was with respect to, again, just the number of people that are impacted because of long-term care. And it's not to center or focus in that space, but I think it is a place where people really do not realize the level at which Medicaid is supporting, again, our parents, are, just so many different individuals in that space. And I think it just is really impactful.
And, it's important, I think, on that point to really understand what long-term care is, long-term services and supports, community-based services.
Mhm.
We're not just talking about grandma in a nursing home.
Yep.
And I hate to say it that bluntly, because I think, unfortunately, that's largely the only place people's minds go to. But we're talking about children who have disabilities, whose parents need support in the home to take care of them. We're talking about adults who have disabilities and they need help in the home with, activities of daily living so that they can live their best, most productive life. And so to think about taking away those kinds of benefits, knowing the central role that Medicaid plays in long-term services and supports, it's necessary to understand the cost of those services, who they're benefiting, why they're necessary. And when you're talking about taking out almost $900 billion in funding, that doesn't just come from fraud, waste, and abuse, which, I think some reports have said, at its highest, that might be somewhere around $50 billion, fraud, waste, and abuse in the Medicaid program. So it's important for people to not get distracted by the sloganeering and really understand what's being talked about. And so on that, as we continue to look at what are some of the big proposals on the table, I think there are a couple we want to talk about. I'd like to start with work requirements, because this is one of those that I think, Medicaid is one of those almost archaic programs with the language and the terminology and the math. And people just kind of go, block grants, FMAP, whatever, stop talking. But work requirements, people go, oh, I understand that. But for me, this concept of imposing work requirements in the Medicaid program is largely a solution in search of a problem. And that's because about 91% of the Medicaid population currently works, is in school, or they're full-time caregivers. And if they're not working, it's because they're retired, or they have an illness or disability that keeps them from working, or, of the small percentage of adults who could work but aren't working, it's not because they're not trying. A lot of them are unable to find work. And you see that increase more when the economy dips and unemployment is high, which we've seen in recent years. So this idea that the folks on Medicaid aren't working, and so in order to keep their Medicaid, they avoid working, which I've recently seen, and I'm not going to remember the name of the person, but a member of the House specifically, who alluded to that people aren't working because if they work, then they'll make enough money and they won't be eligible for Medicaid. And that is just simply untrue for the vast majority of the enrollees in Medicaid. And so when we look at this proposal, we go all the way back to 2017 or even 2018, when the first Trump administration issued the guidance letter that states could use the 1115 waiver process to impose work requirements on their Medicaid population. We saw several states at that time willing to do that. And I think at the time, the administration approved 12 state waivers, but the majority of those never went into implementation because the matter was brought before the courts, and lower courts found that at least the way that the administration went about it was not permitted, and work requirements were not part of what was imagined by the architects of the Medicaid program. And so the courts essentially stopped implementation of work requirements. But when the issue went before the Supreme Court found the cases were no longer relevant. They were moot because the Biden administration had taken over and they had stopped the vast majority of work requirements at that time. Come to 2023, we get another House bill that introduces work requirements, and it would require work requirements in all states for all Medicaid populations. And I think what is important to understand is many of the states that had been interested in work requirements in 2018 were mostly focused on the expansion population, the 18 to 65 adults who were childless, perhaps unmarried. So looking at that population in particular, but the House bill in 2023 would say everybody who, all adults on Medicaid, regardless of, maybe disability status, et cetera, would need to engage in some work or be in school or otherwise meet an exception that maybe the state decided. That was not enacted into law. And now here we are again in 2025, and work requirements again are back on the table. But I think what we need to understand is the policy fails to recognize what Medicaid actually does as it relates to work. So not only are people who are on Medicaid working, they do tend to be working in jobs like service sector, retail, agriculture, construction. These tend to be lower paid jobs like construction laborers. And they tend to be jobs where employer-sponsored insurance isn't an option. Forget about whether it's affordable, it's just not made available.
Yeah.
And so you add that to the fact that the evidence shows that actually having access to health insurance is what increases a person's ability to obtain and maintain employment. So when you think about that and you look at the facts, you look at the evidence, you see that this policy of work requirements really isn't about increasing employment, because the evidence shows that taking away somebody's health insurance affects their ability to work, and they're much less likely to be able to obtain and maintain employment. So then I ask, well, then what really is it about? And what it appears really to be about is just reducing the number of people who are enrolled in the Medicaid program and potentially garnering savings by covering fewer people. And we absolutely saw that in Arkansas, which was the first state to have work requirements. They don't currently. It's no longer imposed, but 18,000 people lost coverage. Not because they weren't working, not because they didn't meet the work requirements, but because, one, they didn't know that it existed. They didn't know that they were required to file paperwork. The means with which paperwork was able to be filed were not accessible to everybody. So huge administrative or bureaucratic barriers is ultimately what resulted in people losing their coverage. And this wasn't because they weren't working. It was just because they didn't know or they didn't file the paperwork in time. And when you look at the Congressional Budget Office estimates, back at the 2023 bill, you see exactly the same thing. CBO was very clear. People will lose Medicaid coverage and employment will not increase.
Yep.
And so this is why I kind of keep going back to that. It's like a solution in search of a problem. It's not going to do what it is purported to do. The other thing that we know from the states, Arkansas and Georgia, and the other states that put forth waivers, it's not a, okay, now there are work requirements, magic wand is waved, and voila, all of the infrastructure is there in order to implement that. And in fact, in those waivers that those 12 states put forth, the cost to set up the infrastructure needed and the personnel needed to administer work requirements was anywhere between $10 million and $300 million. The vast majority of that would be federal dollars because of the way the program is paid for. And so it isn't clear when, earlier in January, or even most recently, when there are statements about, it'll save $100 billion if we impose work requirements. It's not at all clear to me who's figured out what the implications are of the cost to first set up the program and then to run it continuously. Georgia right now still has work requirements. And at the end of 2024, or the beginning of this year, it was identified that Georgia has spent $40 million in implementing its work requirements for 6,500 people. There are only 6,500 people enrolled in Georgia's Pathways program, $40 million to administer the work requirements, 80% of which was for administration and consulting fees.
Yep.
So I go back to, what problem really is this solving? And so if Congress doesn't enact work requirements, the Trump administration can go back to what it did in 2018 and try to use the 1115 waiver authority to do this. But I think if that happens, we end up back in the courts, and the Supreme Court is going to end up having to make a decision about whether, one, work requirements are permissible in the Medicaid program under the statute, and if such requirements can be administratively imposed without congressional action. So again, we're going to have this uncertainty even if Congress manages to move forward with it, because past legal interpretations are that this isn't permitted under the Medicaid statute.
Right. Oh, yeah. I was going to say, I for those not watching the visuals, my head was nodding the entire time with respect to Michelle's just overview, and it can be really maddening when digging into just this information and data related to, especially around work requirements. So, I think that's a key policy component that's coming forward within the different pieces of legislation, and has really been a focus area, I think, for many of the Republicans as they've been looking at reform around the Medicaid program. I think two other areas that we wanted to highlight, I think especially because of the alignment. Let's start with sort of the block grants or per capita cut that are being proposed. And the reason why I bring that one up first is because it's interesting that the results in, if they were to move forward with their approach, is approximately $900 billion in savings. I'll say again. And so looking at that very, squares up nicely with what's being proposed in the second, or in the markup of the House, the budget reconciliation bill. And so what do we mean by when we talk about sort of block grants or per capita, the caps? And so again, currently the federal government pays a fixed percentage, whatever the costs are to the program. And really, if you look at a per capita cap, that would really restructure the way in which, states receive funding around Medicaid. And it would restructure it to fund sort of based on a per beneficiary basis, regardless of actual state costs. And oftentimes, these caps are really built not to keep pace with expected growth in general, let alone, let's say, God forbid, we have another pandemic, or we have new and innovative drugs coming into the marketplace that, have not been, projected or incorporated in. I just think it's just really, phenomenal, especially as we've been looking at some of the impacts around costs related to GLP-1s and thinking about, those components. And so I just think it's really important to consider that really those caps are not going to be incorporating any possible, changes that could not be predicted. And as I noted, really looking at that proposed impact closely mirrors what's being, aimed at with the budget reconciliation bill. I think the other piece is that we know that right now in the United States, our healthcare system is more expensive than others in the world. We need to address that. We need to keep working on that. And when we are looking at this approach, we're not addressing the fact that our system is still really expensive. We're just restricting what Medicaid can actually receive to sort of pay for this. And again, there's an impact that would lead to states having to figure out how to fill the gaps that would definitely occur. And where do you start to go for that? You look at cutting current programs, benefits, and eligibility for individuals. So that's one really sort of massive way in which Republicans are looking at shrinking the Medicaid program. And then the other sort of really sort of fundamental way in which the Republicans are looking at potentially restructuring the way the program is paid for is really shifting the FMAP, or the federal matching rate, and really reducing this. And so all states have a federal matching rate, and kind of different rates, but really on average across the board, you're looking at about a 57% for sort of legacy populations. But as we look at the expansion population, which has really been a focus and a target for the Republicans when we look at the restructuring of Medicaid, that is 90% match rate from the federal government. And so what the Republicans are aiming is looking at reducing that to the 57%, or sort of the average match rate that states would have, really greatly, reducing then the ability for states to fund and cover the populations that have been covered through expansion. And I think that the one other piece that I'll say is that the federal government is also looking at sort of having a more aligned federal match rate across states. Some of those do fluctuate. As I noted, the average is about 57%.
I think just quickly, Kat, just kind of hit that point harder on its head. The FMAP is determined based on a calculation. Like I said, math is hard. And ultimately what it ends up determining is, what can a particular state contribute to the Medicaid program, sort of based on I'm going to say the wealth of the state, even though that isn't quite accurate. But to be specific, Connecticut, I think, has an FMAP somewhere around 50%, which is the floor.
Right.
A relatively wealthy state. But then you look at Mississippi, which is a relatively poor state, and I think their FMAP, for the traditional Medicaid, so we're not even talking expansion, which they haven't done, but is somewhere around 80%. And so when you start to talk about shifting the FMAP down to be more in line with kind of what that average is, what's important to understand is the states who need that money the most are the poorer states. And that money is less likely to be replaced in that state, because if they had it to begin with, their FMAP wouldn't be high.
Right. Yeah, that's a really great point, and thanks for bringing that forward. I think the other piece to note about the expansion population and looking at that reduction is that you have a number of states that have sort of trigger laws connected to their expansion population, and that if the FMAP rate was to be reduced by the federal government, you have a number of states that would immediately eliminate the expansion population coverage. Or have a couple, I think it's 3 states that have that the legislature would review the impact. And due to the impact, again, not to make assumptions, but one could move forward with the assumption that they may cut the expansion population. And I think that, again, this is just when thinking about sort of how this touches our communities and our neighbors, looking at, we've seen with Medicaid expansion, we've seen an increase in the number of children that are enrolled, because as adults have coverage, they then recognize the importance and coverage for kiddos.
Mm-hmm.
And look at improvements in infant health, because again, the coverage of births, you're looking at educational and health outcome and overall impacts and improvements. And coming back to, again, family financial security when they have access to health coverage as well. And so in effect, while not sort of officially the letter of the law of like a repeal, you are in effect repealing the Medicaid expansion that came forward in the Affordable Care Act and has just been so important to so many states and individuals as well.
And I think that's really important for folks to understand, that if in the, vein of saving money, the enhanced FMAP is reduced or removed, it is essentially a repeal of the Medicaid expansion, because for the most part, as we explained, states are not going to be able to find that money elsewhere in order to fill in those gaps.
Yeah.
Particularly states that are currently already experiencing budget deficits, that they're trying other ways to fill in, and that's just to keep things at a status quo. And then at any point in time when, it's, I forget what the word is, it's not going to come to me right now, but the concept is that the Medicaid program, when everything in our economy is doing very, very badly, high rates of unemployment, whatever it might be, the Medicaid program becomes that much more important, because people can rely on it when their usual sources of coverage are not available. Well, that happens at the same time, typically when tax revenues in the state are reduced because employment is down, businesses are closing. And so the importance of that federal funding at all times is necessary in order to continue to support the Medicaid program, again, when people need it most. And so we can't decide in any one moment who needs it most and what that ends up looking like, because it is not that simple. It's not that black and white. The facts and circumstances of the economy, of public health, the global economy, of so many things affect the need for and availability of the Medicaid program.
Yeah.
And I think that understanding that the Medicaid program helps in all of these different ways has been an important driver at the state level in the last 10 or 15 years to really think about what constitutes health and health care, and what should the Medicaid program be buying, what should it be paying for. And I always go back in my mind to Dr. Cohen when she was secretary of the North Carolina Department of Health and Human Services program. And she talked about Medicaid expansion, and she talked about the Healthy Opportunities pilot, and her position was, I want the Medicaid program to not just pay for health care, but I want it to purchase health for our community. And so we've been able to see through innovations through the Medicaid program this smarter way of thinking about Medicaid and how it can be used to drive ways of envisioning healthy people and healthy communities. And that's why we've seen in recent years, states like North Carolina through its Healthy Opportunities pilot, and Washington through its Foundational Community Supports program, and other states are using Medicaid dollars to go further upstream in a person's life and try to get to the things that affect their health. It's not just about you broke your arm and now you need an x-ray and you need it splinted and you're going to need physical therapy. It's how do we help people obtain their best health and well-being? And so thinking about and understanding that housing is a component of health. Yep. And ensuring that you have access to affordable and healthy food is a component of health. And, making sure that you've got access to safe living in working environments, and that you can access transportation to get to the places you need to get to. We've seen states like North Carolina and Washington using Medicaid funding to build that infrastructure and to try to fundamentally get everybody, health and human service providers, the people receiving the services, taxpayers, et cetera, to begin to rethink what healthcare is and shift this mindset to health and purchasing health. And with these significant reductions in the Medicaid program, these innovations to address these health-related resource needs are probably unsustainable in the states that have been doing it. And the states that saw the benefits and are moving in that direction wouldn't be able to go there if these cuts are put forward.
Yeah, I think it's really an important point. And, even building on that and really thinking about, the intersection of health and other systems beyond sort of what the Medicaid program has been able to cover, and not to, divert down, but recognizing that within the budget reconciliation proposals and the Senate proposal, you're looking at cuts to so many other programs in, housing and urban development, and looking at USDA and sort of the food programs that are coming forward in there. And so thinking about not only what may impact the Medicaid program and the, strides that it's made in really recognizing that health is broader than healthcare, we are also looking at cuts across other programs that then are just going to sort of mutually impact the same communities and individuals that are already seeing this, and then states having to sort of think through some of those challenges as well. So I think it's important to sort of elevate that piece too.
How it all kind of fits together in this intricate the game Jenga. Pull the piece out and the whole thing might fall down.
I think, in addition, as we noted, we know that as cuts start to come forward, again, hopefully we can fight and we can make sure that we are, protecting Medicaid, but we know that there are going to be, looking at programs, benefits, eligibility. And I think a specific area that's really important to call forward is, the United States has really been subpar in our performance around maternal health, and we are striving to make improvements. And some of those areas of improvement within the Medicaid program, as we noted, almost 50% of births are covered by Medicaid, is looking at expansion of coverage and eligibility for individuals, to really make sure that pregnant people can, feel comfortable and secure both in the prenatal and postnatal periods, and really sort of having that support. Additionally, many states are exploring options around midwifery and doula programs to have really culturally responsive care for the Medicaid and for all communities. And again, when we think about cuts and impacts and decisions that states are going to have to make, thinking about some of those programs, that those may come forward and it will really set us back again. And it's again a space where I hope that we can continue to fight and push for and recognize the impacts that that's having across our country and our communities. It's scary just to think about just the backward steps that we may be taking as we're moving forward,
particularly for such a potentially vulnerable population. These are children being born, and the people who will care and raise them. We need to take care of them in order to ensure that ongoing health in our communities. It really is starting to think about these programs in less of a transactional way and more of their longitudinal impact and importance. A healthy pregnancy, a safe and healthy birth, that first year of postpartum, having both, the child supported and the parents supported, it makes a huge difference. I had my son, and oh my goodness, the amount of support that I would have liked to have that I didn't have It just makes it so much easier and healthier for people.
Yeah.
I think the other thing to think about is what is the role, you talked about our healthcare system is the most expensive in the world, and that probably doesn't make sense. And reducing, the ability of an insurance company to pay for services doesn't make the services more affordable. So how do we continue to look at innovations and ways to address the cost of care that maybe isn't always logical or reasonable in our healthcare system? And what is the role that Medicaid has been playing in that?
Yeah. Well, I think it really shows, I always saw it as such an opportunity with respect to Medicaid to really be sort of leading out in front and thinking through approaches for innovative payment methodologies. And I think one of the drivers of that has been through the, Innovation Center that was developed out of the Affordable Care Act, CMMI, and, their work in really long ago, sort of pushing states around, state innovation plans. But also, as we've looked more recently in the past administration, looking at models really focused on maternal health. So the transforming maternal health model. There's the integration for behavioral health model. So there was a number of models that came forward and really thinking through some of these key issues that are facing our country and the Medicaid program, and really thinking through how providers can be more coordinated. What does that look like? How are we driving equity within programs, centering the voices of people most impacted, and sort of how this work is designed, leveraging and really building in, peer and community workforce, and sort of what does that look like? I think also, considering multi-payer models that have been coming forward out of CMMI and having more alignment across the, numerous payers that are within our healthcare system, and states really pushing forward on that. And we are seeing in some of the cuts that are happening with respect to staffing, we are seeing direct staffing cuts happening to the probationary staff that have been hired on to move some of these payment models forward. And so, what's going to come of that as we start to see, again, staffing challenges that will impact the programs overall, both CMMI, but also, CMS and our healthcare system writ large as well. The one piece I wanted to just flag, which has been an issue as I've been working on, just how do we build equity within our health and healthcare system? And one of the, a key component is really understanding who are we serving and collecting the, right data. It has been such a slow march toward, how we're collecting the right data, disaggregating the data to sort of better understand where we're seeing disparities and inequities. And a recent announcement came out of CMMI that they are no longer requiring their grantees to collect race, ethnicity, and language data and disability data. And it just was, again, just sort of a sigh that I had of there's been so much movement in really looking at, not only shifting how we collect it, how do we broaden the categories that people are collecting? And again, it's just even collecting the data. It's such a small part, but even that is being pushed aside and ended, and it's just really, just unsettling.
And this point about data is really critical because the payment models, trying different ways to pay healthcare providers to deliver we've heard it a million times, the right care to the right patient in the right way at the right time. If we don't pay for caring for the person, we get more of that transactional cost where it's sort of like every time you do a thing, there's a cost associated with it. Well, you can't get to payment models that are meant to accommodate affordability and quality without data. You cannot do it. And so removing access to the data doesn't improve our ability to get to these payment reforms, which in and of themselves help lead to improvements in costs within the Medicaid program. So again, it kind of is back to that really what are we trying to achieve here with the policies that are being implemented right now. So we've talked about many things. Let's talk about now, what can people do? Where do they go from here?
Yeah. I mean, I think something that I've been really sharing, it comes back a little bit to how we are all impacted by the Medicaid program and centering our stories and our lived experiences in this work and really encouraging others to recognize that their stories are important as well and to call your legislators.
Mm-hmm.
I mean, definitely focus at the federal level. I have the 5 calls app, I think it is called. And I also have my legislators' phone numbers in my phone. I think I saw a recent meme that said the new thing is drunk dialing your legislators instead of your ex. So get those talking points down and, start going. But I think also, again, and don't feel like you called them once and that's it.
Check, done.
Keep calling. I mean, just keep sharing why these programs matter. But also I think reaching out to your state legislators, reaching out to your local legislators, not only are they going to be deciding on programs that are impacted by the Medicaid program, but also they have relationships with all of the legislators that are representing your state and your community. And if they are also hearing from you, they're gonna elevate that up to others as well.
And I think that's really important to understand. Should I be calling the mayor or my city council member to talk about what it's going to mean if the Medicaid program is cut? Yes, you should. Yep. Because it all goes down to the local level. And so if the local policymakers, decision makers understand the impact on their constituents, it goes up to the state level, legislators and the governor's office, which then goes up to the federal level, members of Congress and the administration. And so we all need to be talking to each of those levels so that they understand, which means that you yourself need to be educated about what this is, what it isn't, what is being done versus what is being said is being done, and understand how it's going to affect you, because it will, even if you yourself are not on Medicaid, it will absolutely have an impact on you. So continue to educate yourself, understand the validity of the sources you're getting your information from so that you can speak through an informed, factual lens. And then also collaborations and partnerships. In my time when I was in DC for several years, there was this interesting term that was always used in the healthcare realm of strange bedfellows, meaning when patient advocates would partner with healthcare systems and insurance companies to all make the same argument about why a policy was or wasn't a good policy. So think about who the potential partners are and how you can work with them. Because again, we know in politics, power is important, but so is the individual voice. And so figure out how to exercise both of those through partnerships and through your own story.
Great point. I just was, going to say, I think there's a lot of great organizations out there that are bringing forward a lot of, really important information. I mean, I always look to the Kaiser Family Foundation and, their regular reporting. I have appreciated, the Commonwealth Fund and their efforts. I also think that, Community Catalyst and Families USA are really, again, bringing folks together, bringing information that I think, again, can be helpful to educate folks. And then recognizing as well that it can be overwhelming what's happening at the federal level, and just to center your voice, reach out to your legislators, as well as recognize that we need to build structures of community care as much as we can. And so talk to your neighbors and think about mutual aid. Think about the ways in which we can support each other while everything is going on. I think it's really an important thing to also just be keeping front and center as we are moving through this time right now.
Absolutely. Well, thank you, Kat. I appreciate all of your knowledge and perspective, and we'll talk with you soon.
Yes, definitely. Thanks so much. Bye.